Hello and good evening. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. I want to thank you for joining us for our webinar this evening, The Health Divide, How Social Inequities, Impact Black Wellness. And we have several speakers joining us this evening. I do want to note that this is being recorded, so it will be available for watching later on. Again, you're attending an event put forth by the National Pancreas Foundation, and we are an organization that is unique in our mission that we address all forms of pancreatic disease, from pancreatic cancer to pancreatitis, and all of our programs are built to support the medical professionals as well as our patients and their care providers. A few things that the National Pancreas Foundation does is we have awarded over 5 million grants during our almost 30 years. And we endorse 180 centers of excellence. So if you're looking for care or treatment specializing in an area of pancreatic disease, feel free to look at our website. And then also we provide over 30 programs similar to this for patients, physicians, and again, our care providers. For tonight's program, we would like to give a special thanks to sponsors for our educational events and webinars. As I mentioned, we have a variety of programs throughout the year on behalf of the National Pancreas Foundation. Some of those events are award celebrations. We have several of them across the country, so look forward to you joining us if you are in the community for these events. These are up to date if you follow us online through our newsletter, social media, and also on our website. So if there's an event in your area, please join us. Ticket information is available online as well as through our email newsletters. Another opportunity, if you are a runner or know somebody who is, we offer Running for a Cure with the National Pancreas Foundation. We sponsor bibs for fundraisers at various events throughout the country. We participate in the New York Marathon, the Marine Corps Marathon, the Flying Pig Marathon, and have a few other events potentially coming on our calendar. So if you are a runner and like to run for a cause, please reach out to us to secure your bib today. Additionally, to help our programs run, we are always looking for volunteers. We have over 28 centers and chapters across the country of volunteers that participate. They work with our centers of excellence to table at healthcare fairs in their community. They sponsor pancreas bowling events and do educational events. We also have folks that serve as advocates and march on the Hill or schedule Zoom calls with their representatives, as we are an advocacy organization to support healthcare. And part of that discussion we'll be having more this evening. So if you're interested in volunteering, there's always an opportunity to be involved. Reach out to the NPF and we would love to have you join our volunteer team. Additionally, as I mentioned, all of these can be found on our social media outlets. So no matter where you are on the social media, feel free to follow us, share our information, and provide that resource to the community. Just spread the word about pancreatic disease and all the programs that we are providing. In addition to this webinar, our next one is coming up on March 19th, focused on pancreatic cancer. You can register online. Again, this email is a QR code to register immediately. There are links on our website as well as on social media and our newsletter. So make sure that you follow us and subscribe to get these up-to-date webinar updates and registrations. And again, this evening, we're here for the Health Divide, How Social Inequities Shape Black Wellness. And our moderator for this evening is Dr. Darwin Conwell, a distinguished physician and academic leader who currently serves as the chair of the Department of Internal Medicine at the University of Kentucky College of Medicine. Dr. Conwell's journey in medicine has been deeply influenced by his upbringing in the Appalachia, and he has expressed a strong commitment to improving healthcare access and outcomes for underserved populations, particularly in rural areas. His research and clinical work has focused on chronic pancreatitis, diabetes, and pancreatic cancer, with a special interest in the interrelationships between these diseases. Dr. Conwell is also known for his dedication to mentoring the next generation of physicians and researchers, emphasizing the importance of inclusivity and addressing the health equities in the medical field. Dr. Conwell also serves on the NPF Board of Directors for many years and has been an active volunteer. We appreciate him mediating this session this evening. Make sure that you put questions in the chat so we can address those at the end. And we will have a survey at the end of the session as well to collect information on other areas that we can provide webinars or information. So I'm going to turn it over to Dr. Conwell now to start off our program and introduce our panelists. Thank you, Dr. Conwell.
It's great to be here again with the National Pancreas Foundation. And Jenny, thank you for that kind of introduction. I'm going to start us off with just a few points to go over to kind of set the stage for our two featured speakers. I'm going to share my screen and just discuss a few things to kind of set the stage for us all to get us ready. Okay, so the Great Health Divide, how social inequalities shape Black wellness. The NPF African American Initiative, why are we here on this webinar? An overview of this health divide and systemic inequalities will be presented by myself, Dr. Radmila Choate, and Dr. Cemal Yazici. I'm going to use Kentucky, the state of Kentucky, as an example, as a case study to help frame what we're going to be talking about. There are place-based disparities in health outcomes. Key concepts may include racial segregation, economic disparities, such as financial toxicity, which you'll hear about from Dr. Choate, rurality and social determinants of health that you'll hear about, and social vulnerability that you'll hear about from Dr. Yazici. We cannot impact all of these as individuals, but as groups we can. Some of the areas I've highlighted in red are areas that we can strategically participate as a community and a group to impact. Racial segregation and historical context, we know there is a history in our country that has led to some of the disparities that we currently have in different groups throughout our nation. There's concentrated poverty and social exclusion resulting in economic disparities, and financial toxicity is the term we want you to take away from here. That'll be emphasized later in the talk. There's higher unemployment and lack of wealth accumulation in some of our groups with lower property values and generational wealth impacted. We also know that some of our neighborhoods are considered food deserts or food swamps, where there's not a lot of healthy food options, or where there's bad food options, high fat options, high cholesterol options. There may be more smoking. There may be more advertisements for vaping and other poor determinants and things that impact our health. We also know there are urban and rural environmental challenges, litter, noise pollution, and their effects can be dramatic on health. Policy and public safety, over policing, fear of crime, psychological impact. Some of these things we can impact, others we cannot. Some things we can impact as a group by voting your right as a citizen of the United States, and casting your vote and trying to impact laws of change to improve the life of everyone in our country. There's education and income gaps that result in people receiving fewer health benefits, that results in poor housing and education. There's chronic disease burdens, higher rates of hypertension, diabetes, heart disease, and mental health issues that also contribute to the health of a person. Fear and insecurity, reduced physical activity, and social engagement also can impact your health. Health equity focused solutions. And what are some of the strategies that we can do? Expanding access to quality healthcare and prevention, economic and social interventions such as job creation, workforce development, housing equity, community-led change. And that's what this is really about today. How can we, as a community of people interested in pancreatic disease, you may be a patient with pancreatic disease, you may be a loved one who has a family member suffering with pancreatic disease, you may be a family that's lost someone to pancreatic cancer. What can we do to make a difference in the lives of these people? Law enforcement reform, that's needed. You're going to have to cast a vote to change those kind of policies. But there are some things that we as a group and a community interested in pancreatic disease can do to help. As a case study, I'm going to show you cancer disparities in the state of Kentucky. If you look at Kentucky, the cancer burden is very, very high. In terms of all cancer incidence, there's 30,000 new cases of cancer per year. If you look up the nation, Kentucky is considered a hot spot for cancer. All cancer mortality is 10,000 deaths per year due to cancer in the state of Kentucky. Kentucky is among the top 5 worst states for all-site cancer, lung cancer, colorectal cancer, kidney cancer, brain cancer, melanoma. If you look over to the right, there are also conditions and risk factors such as people living in poverty, adults without a bachelor's degree, obesity, lack of physical activity, smoking, that all contribute and increase the risk of developing cancer. Social determinants of health will be discussed further by Dr. Yazici and also mentioned by Dr. Choate, but 17% of the population live in poverty in Kentucky. 45 counties in Kentucky have persistent poverty. If you look at the United States and compare it to Kentucky in terms of college degrees, there are less college degrees. If you look at people below the poverty line, there's more people below poverty. In terms of uninsured, there's less people uninsured. On Medicaid, more people on Medicaid, and obviously more rurality here in this state. So I want to conclude this first segment and frame this for us. The health divide is deeply rooted in systemic inequalities. We cannot address all those individually, but as a group, we can. So addressing poverty, education, social determinants of health, and health equality are the key. Policy reforms, economic investment, and community empowerment are essential. And we're going to show you how and give you examples of how you can engage, educate, and then empower the community to make change. So there's a call to action. We need sustainable solutions. We need equity-driven interventions to improve wellness and to help our communities. We need to engage, educate, empower, and then do community engaged research right where people are at to help them make the changes that they need. So now I'm going to introduce Dr. Radmila Choate, who is an assistant professor of medicine here at the School of Public Health at the University of Kentucky. And it's been my pleasure to been working side by side with Dr. Choate as she will talk about financial toxicity. And this term may be very new to you, but I guarantee you when she talks about it, you're going to know what exactly it is. And you're going to say, I felt it, or I've seen someone with it. So Dr. Choate, tell us about financial toxicity and pancreatic diseases and the burden beyond the diagnosis. Thank you for being here.
Thank you for the introduction, Dr. Conwell, and hello, everyone. Thank you for being here today. My name is Radmila Choate, and I'm a public health researcher at the University of Kentucky. Today, I will be talking about an important yet often overlooked aspect of living with a pancreatic disease, financial toxicity, with a focus on financial burden in chronic pancreatitis. In today's talk, we'll cover three main objectives. One, what financial toxicity is. Two, how financial burden impacts patients' health, their daily lives, and how it affects their families. Third is what we can do at the patient, provider, and community level to address this issue. By the end of this talk, I hope you will have a better understanding of this problem and will feel inspired to be part of the solution. We often think of toxicity in medicine as something caused by a drug or treatment, like chemotherapy leading to nausea or fatigue. But there is another kind of toxicity that many patients experience, financial toxicity. This term was first introduced in cancer research when doctors noticed that many patients weren't just suffering from the physical side effects of treatment, but also from the financial strain of paying for care. It became clear that financial stress could be just as harmful to patients as the disease itself. So what exactly is financial toxicity? It refers to the harmful impact of medical costs on a patient's life, leading to difficult trade-offs, stress, and sometimes even bankruptcy. The term financial toxicity, first used in cancer research, is now being recognized and examined in chronic diseases, such as diabetes, liver disease, and other conditions. When we think about medical expenses, we often focus on the obvious, hospital bills, medications, but the financial burden goes far beyond that. Financial toxicity has two main components: objective burden, which refers to the measurable financial strain that patient faces, such as medical bills, out-of-pocket costs, lost wages, or debt due to treatment, and subjective burden. This is the personal perception of financial stress. It includes worry, anxiety, emotional distress about medical costs. Both impact patients' well-being, but subjective burden highlights how financial concerns can affect mental health and decision-making. For example, imagine a patient with a chronic disease like chronic pancreatitis who's had multiple hospitalizations. Their medical bills are piling up. Their insurance doesn't fully cover some of their medications, and they are in emotional distress. They're struggling to keep up with daily expenses. So that is financial toxicity in action. Financial toxicity is well documented in cancer. More than 50% of cancer patients report financial hardship, even with insurance. In fact, one study showed that about a quarter of cancer patients incur treatment-related debt, with an average debt of over $26,000. Evidence suggests that average out-of-pocket expenses for cancer care, including premiums, can be over $5,000 a year. But what about patients with chronic diseases? What do we know about that? As we know, chronic diseases account for most illnesses, disability, and death in the United States. They are the leading drivers of healthcare costs. 90% of the nation's annual healthcare expenditures are for people with chronic and mental health conditions. Well, it turns out that financial toxicity is not limited to cancer. 32% of heart disease patients report financial hardship. About a quarter of patients with inflammatory bowel disease and also diabetes have skipped medications due to cost. Patients with chronic liver disease also report high financial burden. What do we know about chronic pancreatitis? While data on chronic pancreatitis-specific financial toxicity is quite limited, but we know that chronic pancreatitis is an expensive disease. It requires lifelong management. Patients endure chronic pain, digestive issues, malnutrition. They may face frequent hospitalizations and costly medications. Hospital charges for chronic pancreatitis have tripled since late 1990s. Although the prevalence of chronic pancreatitis is only about 30-50 per 100,000 people, patients with chronic pancreatitis disproportionately contribute to population-level health expenditures. And yet, we have no large-scale studies investigating financial toxicity in chronic pancreatitis. Now that we understand what financial toxicity is, let's break down exactly where these costs associated with chronic pancreatitis management come from. First, direct costs. They include the medical expenses patients pay for their treatment, such as hospitalizations, ER visits. Chronic pancreatitis patients often have repeated flare-ups that require emergency care. A single emergency room visit can cost over $3,500 and more, and multiple hospitalizations. All this quickly adds up. In addition, chronic pancreatitis patients often require CT scans, MRIs, endoscopic procedures, which are expensive and not always fully covered by insurance. Also, many patients rely on pancreatic enzyme replacement therapy, or PERT, pain medications, and diabetes treatment. For example, a recent study using data from GoodRx, a nationally available drug price comparison website, showed that the average retail price for PERT therapy for cash-paying patients ranged from $1,200 to $1,800 for a 15-day supply. Second, indirect costs. These are the hidden financial burdens that many people don't consider, such as lost income. Chronic pancreatitis symptoms like chronic pain and fatigue make it difficult to work. Some patients have to cut back hours or stop working entirely. Family members also may need to take time off work to care for a loved one with chronic pancreatitis, leading to financial strain for the entire household. And last, but certainly not least, intangible costs. These are the emotional and social costs that don't show up on a medical bill, but they still have a huge impact, such as stress and anxiety about medical expenses, social isolation from skipping events, avoiding travel due to financial concerns, and a lower quality of life because financial strain makes it harder to focus on health and well-being. And this is why financial toxicity is such a major issue in chronic pancreatitis. When faced with financial toxicity, patients develop different strategies to manage costs. Some are adaptive, helping them to continue treatment without compromising their health. Others are maladaptive, leading to worse health outcomes. Let's explore both. First, adaptive coping strategies, they are more effective, such as seeking financial assistance. Some patients apply for copay assistance program or prescription discount plans, but these resources are not always widely known or accessible. When possible, patients may opt for cheaper medication options, though this isn't always available for all medication types. And second group are maladaptive coping strategies, which can be harmful to health. When patients can't afford their treatment, they stop taking it. And this is called cost-related non-adherence. It includes skipping or delaying medications. Patients may ration their medications, such as pain meds or PERT, leading to worsened symptoms and more hospital visits. They may avoid doctor visits due to high copays and deductibles. They may cut back on essentials. Some patients even report sacrificing food, rent, or other necessities just to afford treatment. We now understand that financial toxicity is not just about money. It takes a serious toll on patients' health and their overall well-being. The vicious cycle starts with high medical costs, which lead to stress, anxiety, delayed care, which can actually worsen symptoms, increase pain, fatigue, even digestive issues. And as health declines, patients may need even more treatments, more hospital visits, leading to even higher costs. And it's a relentless cycle that's often very hard to break. However, financial stress has a profound impact not only on physical health, as we just reviewed, but also deeply impacts patients' medical health, social life, overall well-being. Patients may experience mental health, emotional struggles. The constant stress of medical bills and out-of-pocket costs can lead to anxiety, depression, especially for patients already managing a chronic condition like pancreatitis. And over time, chronic stress makes it harder to follow treatment plans and worsens health outcomes. In addition, many patients cut back on social activities just to make ends meet. They cancel plans, avoid dining out, skip travel, because they need to save money for medical expenses. And this can be incredibly isolating, taking away much needed support system. So the impact is not just on the patient. Caregivers and family members often bear the burden as well. So for example, imagine a middle-aged patient with chronic pancreatitis who quits social activities just to afford medications. At first, they may cut back on dining out. Then they stop attending family gatherings, avoid hobbies, and gradually feel more and more isolated. And this isolation can have profound effects on their mental health and overall quality of life. So who is more at risk for financial toxicity? Financial toxicity doesn't affect everyone equally. Some patients are at much higher risk than others, especially when it comes to certain factors, Let's break it down. It's no surprise that lower income individuals struggle more with medical expenses. Even with insurance, copays, deductibles, and uncovered treatments can be overwhelming. Many chronic pancreatitis patients reduce their work hours or leave their jobs due to chronic pain, fatigue, and losing a steady income makes it even harder to afford care. Having insurance does not always mean full protection. High deductibles and limited coverage for medications leave many patients with significant out-of-pocket costs. Some people may be underinsured. That means that they do have insurance, but it is not enough to cover what they need. And for many, the bills pile up fast. Without financial support, this can lead to long-term debt and financial instability. Beyond income and insurance, a patient's personal circumstances can also make them vulnerable to financial toxicity. Let's look at a few key factors. Geographic location, where a patient lives, can make a big difference. Rural patients often travel long distances for specialty care, which means higher costs for transportation, lodging, and time of work. On the other hand, urban areas tend to have higher healthcare costs overall, making routine care more expensive. Patients with lower education levels are more likely to face financial hardship. Why? Because limited education often means fewer job opportunities, lower wages, and less access to employer-sponsored health insurance. But chronic pancreatitis doesn't just affect the patient, it affects their entire family. Many patients need daily assistance, and that means that a spouse, parent, or child would step in as a caregiver. This can force family members to cut back on work, quit their jobs entirely, and this creates financial strain for the entire household. And finally, let's talk about how the disease itself can shape financial toxicity. The more advanced the condition, the higher the cost. Patients with severe chronic pancreatitis often need frequent hospital visits, advanced imaging, pain management, and sometimes surgery, all of which may come with steep medical bills. Many chronic pancreatitis patients don't just have one health issue. Conditions like diabetes, gastrointestinal problems always go hand in hand with chronic pancreatitis. And managing multiple illnesses means more doctor's visits, more medications, and more expenses. So what does this mean? The more complex and severe the disease, the greater the financial strain. And that is why early intervention and support systems are so important. If we want to address financial toxicity, we first need to be able to measure it effectively. Several tools have been developed and validated in cancer research and in a few chronic conditions as well. But do they fully capture the burden faced by patients with chronic pancreatitis? Several validated surveys assess financial toxicity. For example, Comprehensive Score for Financial Toxicity, or COST, a widely used tool, particularly in oncology, consists of 12 questions displayed here. It measures financial distress related to treatment, as well as Financial Index of Toxicity, or FIT. It captures different dimensions of financial hardship. While existing tools provide a foundation, there is a need for a more disease-specific approach to measuring financial toxicity in chronic pancreatitis. Most tools were developed for cancer patients and may not fully capture the unique challenges faced by patients with chronic pancreatitis or specific factors that might not be well accounted for in current instruments. So, what is the solution? Financial toxicity is a real but preventable crisis. Patients should not have to choose between medical care and basic necessities. What can healthcare providers do? They can discuss costs, cost-effective treatment options, financial resources, screen patients for financial toxicity, just like they screen for example, pain or malnutrition. Utilize services of financial patient navigators where available to help patients and their families with the financial aspects of medical care and to help them understand their insurance coverage. Find cost-saving options and reduce stress. What can patients do? Patients can ask about financial assistance programs for medications, transportation, medical bills. Talk to providers, financial patient navigators about their concerns and to explore lower cost options, as well as seek support from advocacy groups, from patients' networks. Addressing financial toxicity is not just about identifying the problem, it's about taking action. One key approach is shared decision-making. What does that mean? It's a collaborative approach where patients and providers choose treatment plans that are both clinically effective and financially manageable by patients. Instead of a one-size-fits-all approach, this ensures that care is personalized based on the patient's health needs, financial situation, and treatment preferences. A paper in the Journal of the American College of Cardiology, shown here on the slide, highlights its challenges and benefits. Financial conversations do matter, but they can be very difficult. Not every patient experiences financial toxicity or feels comfortable discussing it with their provider. A simple screening question, such as asking if the patient is willing to discuss costs, can help identify those who need financial guidance. However, patients might hesitate to bring up financial struggles due to stigma or fear of receiving lower quality care. In addition, providers may lack training or capacity to discuss financial concerns. So how can we improve shared decision-making? We can normalize cost discussions as part of routine care, equip providers with tools and resources to guide patients through cost-conscious treatment decisions, incorporate financial toxicity screening into clinical workflow to identify at-risk patients early. And to close, I'd like to highlight this diagram from our recently published review paper on financial toxicity in chronic pancreatitis. The key takeaways: chronic pancreatitis is a costly disease. Financial toxicity in chronic pancreatitis is driven by direct costs, such as hospitalizations, treatments, indirect costs, lost wages, caregiving expenses, as well as broader social determinants of health, such as economic stability, healthcare access, access to healthy foods. Its impact extends beyond finances, affecting treatment adherence, worsening health outcomes, and diminishing quality of life. So what does this tell us? That financial toxicity is shaped by where a person lives, by their job opportunities, and the support system around them. The more we understand these challenges, the better we can address them. Thank you for your time. I would love to hear your thoughts and answer any questions.
Okay, thank you very much, Dr. Choate. Dr. Yazici will be next. You want to start showing your slides, Cemal? Great. So this is Dr. Cemal Yazici. Will be speaking at the University of Illinois, Chicago, where he is an associate professor of medicine, and he is a longstanding colleague of mine. We share several NIH grants together and are co-authoring papers together. We're really excited to have him here. He's doing great work in Chicago in an underserved population, has a very large population of patients suffering with social vulnerabilities and financial toxicity. So Dr. Yazici, take it away and tell us about social vulnerability and its association with pancreatic diseases in Black communities.
Thank you, Dr. Conwell, for this kind introduction. And I am very happy to have the opportunity to talk about social vulnerability and its association with pancreas diseases in Black communities as part of NPF African American Initiative. I have no disclosures. And today I will cover the following areas. We will briefly discuss increased burden of pancreas disease in Black communities. We will touch on social determinants of health and review structural inequities and social vulnerability. And I will review some of the social determinants of health measures, tools that are available to us. And then we will talk about social vulnerability index and how that has been studied in pancreatic diseases. And then another important area we will talk is about underrepresentation of minorities, especially Blacks, in prior pancreatic disease studies and potential solutions for closing this existing health inequities gap in pancreatic diseases. So racial and ethnic minorities are at increased risk for pancreatic diseases and also pancreatic disease-associated comorbidities such as pancreatogenic diabetes and exocrine pancreatic insufficiency. Specifically, Blacks and African Americans, they are 2 times more likely to develop acute pancreatitis compared to whites. They have higher rates of pain and disability due to pancreatitis than any other racial and ethnic groups. And they are less likely to be transferred to tertiary care centers for higher level of care. And also there are significant disparities regarding pancreatic cancer care in Black communities. African Americans with pancreatic diseases have been shown to have higher rates of organ failure compared to general population, higher mortality, and also significantly higher rates of systemic inflammatory response syndrome. That is when patients present most of the time with acute pancreatitis to the hospital. So we want to talk about social determinants of health. Dr. Choate briefly talk about some of these components. So these are actually non-medical factors, but they have such a big influence in health outcomes. They are the conditions in which people are born, grow, work, live, and age, and pretty much they are the wider set of forces and systems shaping the conditions of our daily life. These include economic policies and systems, development agendas, social norms, social policies, racism that we face in the neighborhoods, climate change, and other political systems. And structural inequities are closely tied to social vulnerability. These include and produce uneven societal, economic, and political environments, which subsequently increase the risk and susceptibilities. These structural factors include inordinate exposure to poverty, violence, and limited access to healthcare and healthy foods, which are quite important in pancreatic diseases. And these structural inequities subsequently can lead to social vulnerability among community members who are living in these neighborhoods and subsequently lead to development of health inequities. So how do we measure them and which tools are available for us to measure them? And one of the tools that are the tools that is available is actually has been developed by National Human Genome Research Institute in 2007. It's called FACG Toolkit. It's a web-based catalog of recommended measures and protocols that have been developed by experts in this field. They are specifically designed for inclusion in the human subject studies, and they are applicable to genomic, epidemiology, clinical, translational science studies. And the FACG Toolkit recommends at least the use of the core social determinants of health measures. And here you will see that they are grouped in 3 categories. The top one, the one at the beginning, is the core social determinants of health categories, and these include access to health services, biological sex, age, address, education level. And in the second panel, you will see individual social determinants of health questions. These include affordability in accessing dental care, discrimination in healthcare, family history of incarceration, healthcare communications, internet access, and other individual social determinants of health. And we have a wider structural social determinant of health toolkit, and that includes pretty much the other structural factors in our neighborhoods, from air quality to concentrated poverty to food swamps and other neighborhood contacts such as availability of parks and walkability. And using some of these variables and creating a unique social vulnerability index, Center for Disease was able to create a unique index measure that we can use quantitatively. It's called Social Vulnerability Index. It provides a quantitative estimate of neighborhood social stress, and it can serve as a proxy for one's overall exposure in the neighborhood contextual risk. You can see that it's grouped into four main domains. The socioeconomic status includes poverty, unemployment status, income, and also education level. Then you have the household and composition, as well as disability status. And the other third category is the minority status and language. And lastly, it has housing type and transportation. And it has been adapted in various disciplines in medicine, from cardiovascular diseases to surgery. And this also has been utilized in pancreatic diseases. Here in Chicago, we utilize this tool to evaluate the social vulnerability in patients with pancreatitis. But one of the challenges that we had in the past in this field is that our pretty much main focus on proximal risk factors that is shown in this diagram. As you can see, we have been paying a lot of attention to diseases that are really, to the factors that are really close to disease etiologies, such as the main drivers of the disease, alcohol, metabolic reasons, hypertriglyceridemia, and such as toxins in case of acute pancreatitis, or underlying genetic suspectabilities, or potentially obstructive lesions causing pancreatic diseases or making the symptoms worse, or the phenotype of the disease, whether if patient had a single mild attack or if they are having recurrent acute pancreatitis attacks with severe disease. But as a field, the distal other intermediate factors, which are also very important in pancreatic diseases, have been ignored and not unfortunately studied in detail. And social determinants of health make up a big portion of these distal factors, including race, education level, income level, social network availability, safety, and so forth. And we specifically look into social vulnerability index in our acute pancreatitis study. And here I will show you two tables. The one on the left side shows the social vulnerability index scores and clinical characteristics of acute pancreatitis patients. You can see that we have minorities and also non-Hispanic whites, Caucasians. And if you look at the bottom of the table, you can see that there are significantly higher percentage of patients living in poverty in the minority group. And if you look at the social vulnerability index, you can see that minorities with acute pancreatitis has significantly higher social vulnerability index compared to Caucasians. And the same study, we also collected the dietary information, which is very important in pancreatic diseases. And if you look into some of the rows, you can see that consumption of some of the nutrients and food items, which is very important for health, are significantly lower in minorities, such as vitamin D. Here you can see the consumption of protein from seafood, which really contains beneficial omega-3 fatty acids, are really low in minority communities. And majority of the patients here in the minorities group are African Americans. The association of social vulnerability index with pancreatic cancer and chronic pancreatitis has also been studied. These are actually, if you look, you will see that these are very recent studies from last year and one from this year. It shows that higher social vulnerability index counties and Black race was associated with increase also of non-elective gastrointestinal cancer surgery, including pancreas cancer. Again, patients in a different study residing in communities characterized by high social vulnerability index were less likely to undergo high-risk cancer surgery at high-volume hospitals. In a different study, patients residing in more vulnerable social vulnerability index quartiles were studied, and chronic pancreatitis patients had significantly higher frequency of hospitalization for flares and lower pain medications if they were living in these high SVI quartiles. Again, in a different study, high SVI was also associated with delay and non-receipt of adjuvant chemotherapy for pancreatic cancer surgery. So it's the whole spectrum of pancreatic diseases, from acute pancreatitis, chronic pancreatitis, to pancreatic cancer. And one of the main challenge we have is underrepresentation of African Americans in pancreatic disease studies, as well as minorities. And here you can see some of the very important studies looking into acute pancreatitis, recurrent acute pancreatitis, chronic pancreatitis, and the role of alcohol and smoking, the importance of fluid therapy, mental, physical, social health. But if you look into the right column, you can see that approximately 85 to 90% of patients enrolled in these studies were whites. So there is a significant underrepresentation of African Americans in pancreas disease studies. And that is further actually increasing the underlying health inequities gap, because if we cannot have our communities represented in these studies, how can we really address and find out and try to come up with a solution? So, and in order to come up with solutions to close existing gaps, there are some areas that we can focus on. These include policy, community engagement, interdisciplinary collaborative approach, and also research. And I will briefly review this. We will start with policy. Implementation of policies to expand healthcare access for people from racial and ethnic minority groups have been successful and improved health outcomes. This has been shown. So reporting race and ethnicity accompanied by other key social determinants of health variables is critically important. And we have to do it transparently and accurately. And this approach actually has been adapted in recently NIH sponsored study that is called DREAM study that I and Dr. Darwin collaborate. And this intersection of policy, implementation, and community-based participatory research also provides very unique opportunities. We can involve and target important lifestyle factors such as diet, exercise, access to fresh produce, but it also requires broader long-term and sustainable commitment, especially from policymakers. So another area is community engagement. So engagement of minority communities is also crucial for addressing health inequities in pancreatic disease. And most of the major institutions have community engagement advisory boards. And it's very important to engage them early on. That way we can raise awareness and engage underrepresented minorities. There are recruitment innovation centers across major institutions in the United States that if we involve, they can help us to increase minority representation. And there are non-for-profit organizations such as NPF, who is organizing these talks under the Black African American Initiative. And these seminars also provide unique opportunities for active engagement and empowerment of African American communities. I want to briefly review the interdisciplinary collaborative approach as well. And it's really critical for increasing the minority representations, because investigators with expertise in health inequities, they can help to develop and adapt critical case report forms to collect the data that we need to address the health inequities. And also experts who work with patients with pancreas disease within minority communities, they can tailor their recruitment retention plans and make recommendations to improve minority representation. If it is a multi-center research, then it is very important to have the data coordinating center. That way, we can really create, incorporate, collect the data, and use the important tools to analyze the data. And also, adaptation and development of novel conceptual frameworks is really needed to study underlying structural factors. And lastly, research. So we really need to improve the minority representation in our studies if you want to really find out and address these health inequities. And incorporation of geographical regions that Radha was discussing earlier with high density minority communities is very important. Therefore, participation of centers that serves these minority communities in these regions is critical. Integration of key data points in study protocols. The example that I have given regarding the DREAM study, it's important. And formation of a recruitment retention committees to address challenges related to minority enrollment and retention is also another factors. And also creation of a diverse research team. So it is very important because of the skepticism that has historical roots in this country to really form a diverse research team. And it really makes a big difference for patients. That also really helps to have these skill sets and cultural competencies needed to engage these patients in longitudinal studies. I think with that, I'm gonna end my talk. I am happy to answer any questions. And I would like to obviously thank all of my collaborators and specifically to Dr. Darwin and also Choate for their collaborations on this topic, and also National Pancreas Foundation for giving us an opportunity to keep this in our radar.
Great. I'm going to show one more slide deck here. So the National Pancreas Foundation African American Initiative, what are we doing and how can you help? You need to be the change that you seek in the world. We need to engage our communities. We need to educate our communities, and that will empower our communities. This is an example at the University of Kentucky, where at the Barnes Staple Brown Diabetes Center Community Health and Wellness event, we had a National Pancreas Foundation table, and we gave out literature that was provided by the National Pancreas Foundation in regard to acute pancreatitis, chronic pancreatitis, pancreas cancer. And you can see, this is my wife, Kathy, here, and also some of our GI fellows and some of our community workers helping us educate patients, educate people that came to the community event about pancreatic disease and the importance of diabetes and other risk factors. The other thing we can do is we can talk about developing a pancreas-friendly kitchen in those patients suffering with pancreatic disease. There's a healthy family recipe cookbook from the National Pancreas Foundation. In the middle is a lady that has acute pancreatitis who won the door prize at our table and got a copy of the pancreas cookbook that we printed off from a PDF. It's also important to engage people where they live, and to touch the Black community, you've got to go to church. And this is actually First Baptist Bracktown Church, actually where I attend. This is my pastor here, but we have multiple events where we can set up tables from the National Pancreas Foundation to educate them on the risk factors and things that contribute to the severity of their pancreatic disease, such as obesity, the development of diabetes, the increased risk of developing pancreas cancer. Advocacy. This is the National Pancreas Foundation that sponsored us to go to Congress and put on an educational briefing to discuss the need for research dollars in pancreatitis and pancreas cancer. Is one of the greatest things I've ever been involved in. And I can't thank them enough for allowing us to go to DC and advocate for our patients. Again, the Black church and health, critical. The church has spearheaded advocacy efforts for political and social justice. It's been a place of refuge and healing for the oppressed and marginalized. This is another church we went to. You can see here several of our gastroenterologists and workers here talking to the parishioners about their health. Again, talking about food, we provide healthy recipes. This is one that we provided last year in 2024 on a bean and beef sloppy joes. This is a healthy copycat recipe of the comfort food classic. The recipe trades beans for some of the meat and bumps up the fiber by 7 grams. We also cut back on the sugar and ketchup in this sloppy joe recipe makeover to save you 12 grams of added sugar. So this was displayed at the church during their announcements, and people could log on and get some of these healthy recipes to improve their health. We also partnered with our University of Kentucky Healthcare and put on a very large holistic health awareness campaign where we talked about everything from diabetes, pancreatic disease, hypertension, high cholesterol, and had screening for colon cancer. And this won an award at the American College of Gastroenterology a couple of years ago. So this is really things that we can do as a community, as a group. Set up a table, get a tablecloth, hand out some educational materials. They're free online. You can print these off and educate your communities about that are in the disparate populations. This is my data sources for a lot of information that I had when I talked about the University of Kentucky and the state of Kentucky. All right, so let's get back on, get all of our speakers on, Dr. Choate, Dr. Yazici, and Jenny Pagel come back on. We've got a few questions here. We've encouraged people to put in questions. So this is a question about transportation. Dr. Choate, you had mentioned transportation as a contributor to financial toxicity. And we know that you're a PhD researcher, so an epidemiologist. So you would be able to identify this in your surveys. But then someone like Dr. Yazici, who's a physician working with the healthcare system, Dr. Yazici, what do we do? What can we do? What have people done in the past when there are transportation issues? People not able to get to their appointments? Are there any solutions that some healthcare centers have come up with to help combat this? Or what can family members do if they're riding the bus and they need to get there to their appointments? Any ideas what people have done in the past, or do you have any suggestions when there is a transportation issue that's contributing to this as a social determinant of health factor?
Yeah, I think for typical clinical need, when we have that challenge, at least in our institution, we have a way through the institution to help them patients with their transportation needs, and that actually happens very common, either during scheduled endoscopy visits or during clinic visits as well. Sometimes, especially our institution is serving a very underserved area, so we have that question come up quite often, and we have the assistance from our obviously the center director, and we are able to get the help that is needed during that time. But obviously that may not be applicable to all of the institutions. So I think probably that will need to be addressed based by the healthcare service. But I also want to make a point, although it is very important in clinical care, the transportation also becomes a very important issue for clinical research as well. That was one of the challenges that we encountered when we were doing our NIH study, but we were able to create and come up with a way to address it, because especially in these minority serving institutions, majority of our patients do not have means to transport. They don't have their own cars. So how we are going to bring the patient, especially if it is really a minority patient that really wants to participate in that clinical or translational science research, then you need to provide that option to the patient, and that is how we are addressing that right now in our NIH-supported study, that we are able to call, ride services for them that picks them up when they are ready 2 hours, an hour before our coordinators call.
That's great.
They say they are ready, and then we call for the Uber, picks them up from the home. They do their research visit, and they are ready to go back. We call for the Uber and drops them, and that is really important to increase the retention rate for the longitudinal studies as well.
And that's an awesome idea. I think I heard about some centers doing that. So that's great. You pick them up with some type of ride share company. So, Dr. Choate, food insecurity. We're going to talk a little bit about food. What do you mean by food insecurity? What does that mean? I may have never heard that term before. Food insecurity. What does that mean?
Well, food insecurity is a very critical topic, and specifically as it relates to the social determinants of health. Food insecurity does not always mean total absence of food sources, but this is absence of healthy choices. And this comes hand in hand with food deserts, right? What do we mean by that? We mean that there are areas and certain zip codes, to answer one of the questions of our viewer, where food choices are very limited, and specifically healthy options are not available. And this leads to a lot of risk factors in view of hypertension, obesity, malnutrition, and such, and leading to multiple chronic conditions. The food deserts are critical. If we want to act, this probably is one of the first priority items that is related to healthy food access.
Yeah, I think that's a very good point. We'll talk some more about food, but these food deserts are important because based on where you live, you may not have, like you say, those choices. You may not have fruit. You may not have some vegetables. And so what we do at some of our health events is we invite farmers in as an opportunity to sell their wares. And what we usually end up doing is free to the participants. And we've already made arrangements to pay the farmers. So it actually helps the farmers. And actually what we're doing is we're actually going to underrepresented farmers, Black farmers in Kentucky, and bringing them in, and that helps them even more. So, and showing them what healthy fruit options are, vegetable options are. The other thing that we do is we bring in a chef and we have hummus, celery, chickpeas, and show them things they may not be used to eating. They can taste it and get saying, this is something I should probably use. Start to purchase. Another thing that I've seen done is we've actually, when I was in Columbus, Ohio, what we used to do is we did grocery store tours and talked about shopping the periphery of the grocery store and not the center aisles where a lot of the canned goods and high salt food was. If you do the periphery, it's where a lot of your fresh produce and dairy products and cheeses are, where it's more healthy choices and selections. But you mentioned food deserts. Okay, now we're going to talk about food swamps. All right, so what are food swamps? These are all terms that we may not be familiar with. So what's a food swamp? Either one of you.
Yeah, go ahead, Dr. Yazici. I will not take all the questions.
No,
I got more questions, no worries.
Yeah, so it is really a concentrated area where you really do not have any access to healthy food. So instead of your typical grocery store, you may still have some candies, some pops, and some other stuff, but you will also have like a vegetable aisle, or at least some aisle that you can get some healthy foods. But in food swaps, it's very high in density in alcohol stores and tobacco stores and so very, very unhealthy fast food chains.
Yeah,
so really limit the patient's ability to access it. So they have to ride and have a car to go to the shopping, maybe drive 20, 35 minutes. And if you're talking about the patient who cannot even have a right to come to the clinic appointment to see you, you can imagine that it is not just one issue having a transportation to go to the hospital, but also it's another issue now of accessing healthy food. So it's all acts in a multiple way. And also in regards to food insecurity, in addition to not having adequate access to food, but it also underlines that people undergo a lot of stress. They feel insecure because they don't have option to buy food or option to buy healthy food. So that stress itself also could act as another trigger.
Yes. So that brings up the term of allostatic load. We don't want to get too technical, but Dr. Choate, tell us about that. So he's mentioning stress, and that could be a trigger. So what is allostatic load? Educate the people on the call. What does that mean exactly?
Yeah, the overall idea about allostatic load is the chronic stress that comes from a lot of chronic conditions that a person has is measured by certain lab values, and it indicates how much chronic stress does an individual's body sustain over time, over their lifetime, from different inflammatory chronic conditions, and how does that impact their physical health, their mental and physical health status, and their quality of life. And what are the associations between this chronic sustained stress on body and health outcomes? And research suggests, and actually a lot of recent studies indicate, that there are strong associations between allostatic load and adverse outcomes. And also allostatic load seems to be significantly higher in the areas where there's higher prevalence of inflammatory chronic conditions, hypertension, obesity in underserved populations. And this is a quite interesting area of research.
Yeah, I thank you for that. That was a great description. And I want to move toward another topic, which is social determinants of health. I mean, just about everyone has heard of social determinants of health, and it became a buzzword with COVID, right? Social determinants of health and COVID infection, and where there's these areas where there's a high density of COVID infection because of their social determinants of health. It became a big buzz term. So, Dr. Yazici, so COVID, social determinants of health, what was that about? And then the other question, part two, is so hospitals are now collecting this data. When someone comes to see me in the office, I see ahead of time where they've collected that data. So my question is, what are we doing with that data? What are hospitals doing with that data? So let's go back to COVID and why social determinants of health were so important during the COVID infection. And now we recognize we need to start assessing this for other diseases. And tell us what, second part is, what are hospitals doing with that data?
Yeah. So it became obviously one of the main topics at that time, because these communities where we really have high social vulnerability were underserved communities, and they did not have the means of accessing either, at that time, protective equipment. They didn't have, enough financial resources to go and buy their mask or hand sanitizers, or they did not have means to go and make an appointment to get the COVID vaccination, because they, did not have maybe even internet access or a desktop to make that appointment online, because everywhere was closed. So then at that time, I think that everyone really realized that this neighborhood that we live in, the environment that we live in, makes a really big impact. Even if it is not really primary medically related area, it really have a major impact on health outcomes. And obviously, being a very highly infectious and high mortality disease at that time, it made the spotlight and made many of us to realize how important it will be in other diseases. And that's why I think it has been studied more right now, at least in pancreatic diseases.
Mm-hmm. Yeah. So Dr. Choate's going to be, he talked about the cost survey and collecting this data. And so it gets to the second part of the question. So Dr. Choate, you're going to collect all this data. As an epidemiologist, you're going to define these populations at risk and all that. So hospitals are now collecting this data. So what do you think is going to be done with this data? How it can be used, ideally, as an epidemiologist, how do you think it can be used? Then I want to hear from Dr. Yazici. Does he know of hospitals that are using this, and what are they doing with the data? So Dr. Choate.
Well, not only collecting data, but of course, analyzing this data is of critical importance, and especially screening for financial burden, which is part of overall social determinants of health perspective. But thinking about financial toxicity data, there are certain groups, certain patient populations who may be more vulnerable to certain aspects of financial burden, such as what we have just mentioned about transportation, about difficulties in paying for certain medications that might be specific to that particular condition. And that also stems to lack of long-term and large-scale studies on financial toxicity in specific conditions. We do have abundance of data on financial toxicity in cancer, in oncology research, but in certain chronic conditions, for example, as chronic pancreatitis, as we talked today, it is important to know what is important to this patient population, what struggles do they experience, and without the data that comes directly from patients' voices and their opinions, it is very hard to plan for any subsequent interventions or develop strategies or to propose any strategies to mitigate this burden.
Mm-hmm. Mm-hmm. So, Dr. Yazici, when a patient's in your office and you prescribe pancreas enzyme replacement therapy, and they tell you, they come back in their follow-up appointment, and you're asking them about that, and they tell you, I didn't get it because I just can't afford it. I went to the pharmacist and it's too expensive for me. What are some of your options? You're right there in front of the patient. What are some of the things that you do to get them that medication? That this be very important for people to know.
Yeah. So some of these medications, the producers, they have their own internal programs to help patients who do not have insurances. They are so-called sometimes coupons and sometimes patient referral programs. So that's one way to go. I think that's an option. And obviously, in our institution for patients who do not have insurance, also we have a charity care. But I think most of the institutions have something in line with that. That can provide, I think, financial assistance to patients who cannot afford. So those are the two options. In regards to the other social determinants of health variables, obviously, some of them collected at certain degree at certain institutions, and it is not very standardized, but that's one of the screening questions as well. When a patient comes, they ask, do you feel safe at home?
Mm-hmm.
Do you feel about hurting yourself? So those screening questionnaires, obviously, if there's anything concerning, that provider is notified at that time, and then we can call the social services to come and help them, or social worker. So that's one of the mitigation strategy. But I think the broader picture is how we can further study and implement this, and try to create a program, not just based on a hospital, but in a city, in a state, or in a nation, to really help patients to mitigate these challenging conditions, improve their health care. And I think that will come to major policy changes in long term. I think that is what is really needed.
And since you talk about policy changes, there is a question in here, and I want to thank both of you, that talks about, will a law be passed one day to allow for assistance for behavioral support, for alcoholism, nutrition literacy, think about it, smoking cessation. What are your thoughts about that?
That's all we hope. Hopefully we will come to that point. But I think the first thing is, the most important thing is really to recognize that these health inequities exist in this country, in our communities. And first we need to recognize that, and then study it really to understand the root causes, and then obviously work all together with our non-for-profits, physicians, patients, patient advocates, lawmakers to push for that.
Yeah. And so just review for the patients again, and people on the call that are, loved ones of patients with pancreatic disease. What are the social determinants that you think are contributing, that are common in people with pancreatic disease, and some of the other risk factors? Help us understand that, because this is, we're talking about, this is the National Pancreas Foundation. We're talking about pancreatitis, chronic pancreatitis, acute pancreatitis, pancreas cancer. So what are some of those things, again, just to quickly tell them some things we should be looking for and trying to eliminate?
Yeah, I think diet is important, one of the important ones, because it's closely related to acute pancreatitis and recurrent attacks, especially given that gallstones and alcohol make the two most common causes when these repetitive attacks happen because of either increased alcohol consumption or inadequate access to healthy foods. I think those are two things that potentially we can try to address and try to eat a healthy diet and try to decrease the consumption if that is the ideology, and other risk factors that are associated with it, for example diabetes and obesity and increased weight. So if we can try to adopt a healthier lifestyle with increased exercise and trying to manage our weight better, that will potentially be another mitigation strategy that we can at least address together with our patients collectively. And obviously there will be a need for a wider policy style changes that will give more options to our patients for them to seek adequate care in timely fashion when they're really worried about the financial toxicity, when they don't have really the insurance or the supplemental insurance or access to care. Probably they don't feel safe or more comfortable reaching out to their providers.
Right.
So,
Great, thank you. So the other question, and this is layering on what you've been talking about before, but helping people understand this zip code. All right, so Dr. Choate, yeah, some of the terms we talk about, we use are geospatial studies and all that. So tell us about zip code and how it relates to this that we're talking about right now. So why would you, as an epidemiologist, use zip code in your studies of social determinants and populations? What does zip code do for us?
Well, that's actually is a very good question because zip codes mean so many things. It doesn't really only impact the actual geographic location where a person is, but the area that surrounds them. So we know that certain zip codes are highly populated with underserved populations, right? So for example, we talk about Appalachian area and we talk about zip codes of rural populations, right? And there are certain factors that may impact, certain risk factors that may impact potential of developing certain chronic conditions depending on the zip code. Also, as Dr. Yazici mentioned in his presentation, social vulnerability index also encompasses zip codes or census codes into identifying these vulnerable populations that are potentially highly impacted, not only by let's say natural disasters as the SVI was initially developed for, but also medical and financial disasters, if you will. So investigating epidemiologic prevalence of certain conditions depending on the zip code and what surrounds our patient population, because social determinants of health are not only medically enhanced health outcomes, but it also where a patient live, play, work, pray, right? So that is what zip code means in view of epidemiologic investigations.
Awesome. That's an awesome answer. I thank you guys very much for this. A couple questions I can wrap up with. There's one question about opportunities for students working with Dr. Conwell, Dr. Yazici, Dr. Choate, anyone. A lot of times at our universities, we do have programs where students can come up in the summer and learn some of the things that we're doing, learn some research methodology and get introduced to academic medicine and research. So those options are available in a lot of places. Working with grade school, middle school, high school students, the earlier we introduce students into these concepts, healthy food choices, exercise, good sleep habits are important for them to have a long-term health. And so we do a lot of that. A lot of us in the National Pancreas Foundation Centers of Excellence throughout the country do a lot of those things in our communities, going into grade schools and middle schools and educating young people on healthy food choices and diet and exercise. Please complete the webinar survey. I want to thank the National Pancreas Foundation, Jenny and Silkfall for putting this together and allowing us to come and talk about pancreatic disease, talk about social vulnerabilities, social determinants of health, financial toxicity. We hope we've given you some new terminology and new nomenclature to go out and have educated you to talk with your provider and get the resources that you need and that you're more informed. Our goal was to engage you, to educate you. Now we've empowered you to make changes for your health. Thank you very much. Thank you, Dr. Choate. Thank you, Dr. Yazici. And thank you all for tuning in to listen to this webinar.